sorry. So I'll pull up the series. And then, as I understand it, the crisis peer support services was also added this year to the series. And so one of the reasons that I had recommended peer services was to expand it past inpatient services to be able to engage people with peers prior to intake to get them to be able to complete their assessments and intakes. And right now, that's not a peer support approved service. So, but I agree with what everybody has said on the team so far, is just how can we engage and transition care. Whether I do think it's helpful if we determine things that are in the WAC that we want to see changed that are barriers to doing that, like the peer support services WAC that was just recently read.
I put it in the chat just in case anybody needs to have the regulation number. And I wonder if there's any way of maybe instead of calling it peer support, calling it something else might be beneficial. I know from doing Department of Health audits, what oftentimes we would see is peers engage in pre-assessment tasks, but there was not like adequate supervision of what was happening, which caused problems for the peers, like boundary issues and different aspects like that. I like the idea of trying to figure out a way to have like some peer recovery support prior, like for the function. I mean, that's exactly, but I don't know how that takes place without DOH redoing that WAC.
Isn't our recommendations related to changing the WACs? Isn't that what we're doing?
That's my understanding too.
So I want to jump back up because I didn't even paraphrase. I kind of made up what you said here, Brandy. But what I heard you saying is that there is a billable peer service for step down from inpatient services, and that we could maybe suggest that we expand that to include not just stepping down from inpatient, but transitioning from community settings.
Yeah, or, homeless populations and, it's called,
we used to call it rehabilitative case management.
We've expanded into a longer, I'm getting it, sorry.
What is the BHA WAC for Washington State around peer services?
I put it in the chat. It's 246-341-0700. And for behavioral health support service, which peer service falls under, is number 3.
And the current billable service technically is called Behavioral Health Care Coordination and Community Integration. But the encounter is when a client is in jail or prison, juvenile detention, CLIP facility, ENT, medical or psychiatric inpatient facility, or unwaivered IMD for the purposes of discharge planning and coordination of care. My concern with that is, I think that's excellent. I love that it's there. but it doesn't allow, so it doesn't allow a peer to provide the services, or excuse me, it does allow the peer to provide services. It doesn't allow for anybody that's not in an inpatient facility or incarcerated to provide that.
So it sounds like we have a specific recommendation for an alteration to this WAC to expand rehabilitation case management services to include transitions from non-inpatient settings with services performed by non-inpatient staff. Am I capturing
To
that?
help, well, to help them get into a, for example, inpatient or outpatient, helping individuals access services, whether, you know,
Yeah.
versus only transition from inpatient level of services. That
Just
it can be bigger than that if
in the context, just so folks know why incarcerated and inpatient is permitted, is because the individual has a previous assessment. So for inpatient, a medical provider has done an assessment, and then for incarceration, typically there will be someone who has conducted a behavioral health assessment. Not always a behavioral health agency, but there's typically a professional. And so SERI expanded to permit billing for that purpose, for that situation.
but it doesn't have it as a requirement to have an assessment or intake completed to bill that service.
Correct, because they're allowing what was previously conducted.
But it doesn't say in the SERI that it's required that an intake or assessment conducted to provide the service. So it's not, I mean, whether the assumption
Yeah, that's the
was
door.
made,
Right, that's the door that you have to ask for. So if SERI's not saying it's required, then why wouldn't it be that you're able to expand this out for outpatient?
because of the peer support services WAC is currently doesn't allow a peer to provide that.
Right. So there's an incongruency between what SERI is allowing and what the WAC is allowing, is what you've identified, which is good.
But I'm not sure if everybody else on this call believes that it should be peer services or any credential. If we're going to focus on rehab case management as a service, I think before we came into the work group, it was just looking at, I mean, I think that's a great service to identify and clear recommendation, so we can continue on that path for sure. But I also want to make sure that other people on the call or are us specifying this.
So there is language in here that seems like we already discussed and decided on this, that this is not a request for peer case management to take place. This is a request for peer engagement. Is that what you're getting at?
Yeah, I think of it, peer support services and case management are two separate services. Case management is not an approved mental health service. It's only an SUD service, although I would love that this would be inclusive of SUD and mental health services, allowing a peer to provide services prior to the assessment or intake. And I do think we need to either say, like, again, peer support services. If somebody wants to add on case management services, that's great. It is limited to SUD only with an SUD credential. So that would change kind of how we write the recommendation.
Is anyone willing to die on the hill of including case management in this? I'm going to give it to Tim Candela 8 seconds before deleting all references to case management.
This would limit, no, it doesn't limit. Never mind. The way that the rehab case management, which is now, care coordination, community support and care coordination, has all credential types, or I shouldn't say all, most credential types listed.
Does the language of community support and care coordination currently include multiple credentials?
Yeah, so it says, and it lists the service may be provided prior to an intake evaluation or assessment, and it lists LPN, registered nurse, AR&P, physician assistant, osteopathic physician, psychiatrist, licensed social worker, licensed marriage and family, licensed or certified mental health counselor, psychologist, MA, PhD, DBHR credentialed certified peer counselor, below master's degree, bachelor's level with exception, master's level with exception waiver, pharmacist, SUDP, and SUDPT.
Does that feel comprehensive enough?
If we want to go with peer services, one of the other credential types that's listed under other billable services that's not listed here is what they call other clinical staff. Let me see what it is. And feel free to go on with something else while I look for it.
Oh, sorry, I was multitasking. All right, is there anything about the notes that I took for this section that feels inaccurate or incomplete? Anything that I need to change in there? Anyone? I can't tell if that means that it's so far off that there's not even any place to start with feedback, or if it's pretty much right on.
This is Brandy. I would say the only thing is the BHA WAC that peer services need to complete a needs assessment or screening. It's actually, I don't believe that's the language. I need to pull up the WAC. I think it's like intake assessment. I think you have to have a treatment plan to determine services. So I think we want to reference the WAC that Lisa put in the chat to identify clearly.
Yeah, the agency has to conduct a needs assessment, which then goes into later that the individual service record and contains documentation that essentially is an assessment. And Brandy, you're going to know this. So on the BHA mental health side of things, I have seen folks use someone who is a peer that is credentialed as agency affiliate to conduct intake engagement and case management. When they're doing their documentation and when they're doing that aspect, they are not doing it as a peer. They are doing it as case management, and they're not using their CPC credential in doing that piece. Is that
Well,
not?
technically, it
Go
can't,
ahead.
it's not a billable service. And technically, mental health doesn't have case management. It's an individual service. So I don't know how they're managing to bill it.
Right. And I wouldn't even have been looking at billing. I would have only been looking at WAC standards. So that's where I was like, okay, wait a minute. So, and people do lots of things that they don't get paid for. So,
Right. There was, yeah. Hold on a second. Sorry. I'm getting distracted by the theory. I can get into it. Just wrapping back around, it does say licensed or certified mental health counselor and below master's degree. So it currently includes all of the credentials, I believe, for the care coordination and community integration. What I was also trying to look at is the outreach and engagement, which is not a Medicaid service like peer support service is, because I think that'll be the conflict, or what they suggest as the recommendation to utilize is outreach and engagement.
right. Because isn't that what Recovery Navigators is using?
I don't know. It depends. It's a state-funded service through the ASOs and sometimes the MCOs, depending on how much funding that they put into contract. I think one of the reasons we wanted to also suggest peer support services be allowable is because it's a Medicaid reimbursable service.
Right.
Again, if this was expanded just past hospitals and the WAC didn't prevent peers from providing services prior to an intake or assessment, then it would alleviate that and allow peers to open it up. So outreach and engagement.
So logistically, then, an agency could leverage existing grant funding for outreach and engagement. A lot of those programs are suggesting that certified peers be used in those positions anyway, and then that potentially you could also provide peer services prior to intake, which would then be billable. So a single FTE could be funded partially by grant funding for outreach and engagement and partially by Medicaid billing for peer services.
Yeah. So when it's outreach and engagement, again, it's not a Medicaid billable service. It is supposed to be an activity that helps bring people in or keep them in treatment. But providers are limited with how much they can bill outreach and engagement services as state funds.
Right.
With this work group recommendation, has anybody from the recovery peer support services been involved on the HCA side?
I'm in the recovery support services section.
Okay.
My programs are primarily outreach, so I'm kind of like not solidly in the center of RSS. I think I'm just kind of in there because there are peers involved in the work that I'm doing and it's recovery oriented. But yeah, it would be great to have someone from RSS who's really well versed in implementation of peer services in this conversation.
Yeah, I think I've worked with them previously when I was with DOH to ask questions about what peers could and couldn't do. And so it's one of those situations where I'm wondering, like, one of the recommendations that maybe gets put forward is to get them to engage in this.
They
so
are
that
on the work group, they're just not in this work group. So this is a breakout session. Lisa, are you newer to this work group?
Yes, I'm, yep,
okay.
I'm
absolutely
group. Brand new. So yes, I apologize for some of my questions because I just want to make sure that like I have, like, I'm like not making any assumptions on my part.
So this will go back to the larger work group, and I believe there's peer representation on that. So I'd suggest that we have the larger work group identify any changes to this recommendation, which I think we're going to do. I think we're going to come back together as a larger group, and we all, have access to these documents to make recommendations. But I believe peers and recovery support providers are part of this at the SUDISA work group as a whole. We can clarify with Michelle on that. Before these move forward from this work group, I believe they're not from this breakout session, but from the SUDISA work group, I believe that there is representation. I wouldn't suggest we write it in here unless for some reason we don't have representation on the larger group that's submitting this as a whole.
Understand.
Hi, this is Michelle. I am present right now in this in this group. So, but sorry, I missed. Was there a specific question for me or something I can clarify?
I think we were looking for a more granular definition of what services peers can perform in various roles, and hoping that somebody from RSS who's not me would have some input on that. I'm not sure. I'm thinking of the broader SUDISA group, and I'm not sure who the individual would be who would be able to speak to that.
Yeah. Okay. Yeah, I'll take a look at the roster and see if I can come back with an answer.
Perfect. Thanks.
Yeah.
And I just wanted to add, this is Angela again. You can probably take out that first sentence where I blathered on about ED social work or ED crisis services. I think it just muddies the waters. I understand now that we are focusing our attention on peers.
That first one, some services already provided in crisis
Yeah.
and ED arena. Okay.
Yeah, just take that out.
But when you, correct me if I'm wrong, when you made that statement, was it to also assure that we include ED, like as part of the description overall, is having peers or other credentialed staff utilize this step down service to connect people?
I mean, we occasionally use peers in various parts of the ED, but I was just trying to look for a way that I could be helpful in this conversation. And I don't think I actually am, because we're not working with getting peers to be billable or anything like that. I mean, this has all been very educational for me, and I absolutely believe that it's a needed service and can really help with engagement. But I think what I have to offer is not necessarily more
So
general.
the services that you were referring to there are services for people that are, so they're provided within the emergency department setting and helping people transition out of that setting into outpatient provider services?
Yeah, really the only peer service that we have is through our OBOT, our Suboxone program, but it's very limited. Monday through Friday, very limited hours. And if someone shows up during those hours, we can ask for a peer to be engaged as they go through the process of getting an appointment. But I think just in general, like all the other things that we're working on are more relevant to this actual recommendation.
Okay, I'll leave it there. I'll just put it in secret brackets so we can pretend like it's not there sometimes if we want to.
Okay, sounds good. Thank you.
I was just going to keep deleting and re-entering it and deleting it and re-entering it to show how we were in flux about it, but I'll just put it in brackets. Yeah.
Okay.
Okay. Are there, in terms of the way that this is worded, this might not be the most clear argument. So the recommendation is to change this WAC. And we want to say expand the language of community support and care coordination to include transitions from community-based settings. So here we can actually take that out maybe then. Okay, so we need to expand the WAC, but Siri already reflects what when there's a disparity or a discrepancy between what Siri is requiring and what the WAC is requiring, the WAC is the thing that needs to change and the Siri stays the same.
So again, this can change. What I was hearing or suggesting was two recommendations that Siri change the community support and care coordination to include transitions from community-based settings to outpatient. Right now it's inpatient jail only. We're missing the homeless population, people who can't access services because they have barriers. And also, I mean, actually, if you add to that, the ED isn't technically considered inpatient either. So those services, although hospital-based is included, you may want to include it to clearly state an ED setting.
Yeah.
And so to expand the Siri for community support and to change the WAC because it's a conflict. Like when peer services are technically allowable as a billable service under community support and care coordination, but community support and care coordination doesn't require an assessment or intake. So that's our recommendation is to.
Okay, so we have to change the WAC to peer supports.
it currently requires an assessment and intake and treatment planning prior to peer services being rendered.
Right. And the way that those are defined, and you'll pardon me for just having a BA in English or whatever and not actually having any clinical background with this. But the way that those are defined, that needs assessment or screening process can't be performed by the peer.
No.
Okay.
By credentialed, I can pull up the assessment. It specifically says like credentialed, and actually we do need to make sure that the wording of the WAC, you know, what we would recommend the change would be, in my opinion, because I've been reading them recently thinking that there was a barrier to, anyway, point being, there wasn't any, sorry, my brain's running a little too sideways. We need to, in my opinion, would make suggestions about how the WACs change, that we as a work group would read what those are so that we have a clear picture of what needs to change. So I'm going to pull up also the requirement that states that around the assessment.
Okay. And then I forget who brought up the supervision for pre-assessment peer services. Is that's something that needs to change as well in the same WAC?
That, I believe, was Lisa's concern, but I'm not sure unless we want to add in there something around supervision.
So it's so incredibly broad that there isn't anything that you would be able to really, like, there isn't a specific WAC that you would be looking at revising. Essentially, you need Department of Health and Healthcare Authority to provide authorization that peers can provide services prior to assessment. Like, go ahead.
How
Okay, so
how DOH interprets the way a WAC is written is also impacts how providers gain access, you know, so how providers are evaluated. There is currently, as written, peer support have to be supervised by an MHP or SUDP, but there's nothing that says that supervision has to be at a certain frequency or certain amount or certain types of things. That's not written for anybody's supervision except like licensed people going for license in the number of supervision hours that they've received. So I think we would be going into a rabbit hole if we're gonna, unless you want to change peer support specifically.
I think that might be outside the scope, but I want to. Adequate supervision might be a challenge if the what am I thinking? If the geography of the position changes. So if a person is providing peer services and then they're doing outreach and engagement, the level of supervision might need to be increased for some of those community-based interactions, just because office-based interactions are a lot easier to supervise and a lot easier to sort of manage quality on.
So I didn't make any of the statements with regards to adding that into the recommendation. I just wanted to let you know what some of the prior issues had been.
Got it. Okay.
And so what it has to do with it has to do with the interpretation of the WAC. So it has to do with, can peer support be provided prior to an assessment? And so that's what you're looking to remedy here based on, you know, Brandy pointing out that there's an incongruency between SERI and what is permitted. And so you have it there all written in.
Okay. Does everyone else feel like this is pretty complete?
I wanted to go back to something that Angela had identified and just ask if it's something of consideration. So if the recommendation is to expand services that can be provided before an assessment, if an emergency department has someone and they need an outpatient provider to engage with that person to get that person into services, what are they currently utilizing to do that?
That's a really good question. I imagine it varies quite a bit.
Yeah,
And-
I mean, it varies completely. The only outpatient provider would be within Arborview clinics. So like our OBOT, our Suboxone clinic is the only way. Occasionally, if we are referring someone to detox, the detox provider will want to talk to them on the phone, and we would just try and get a phone to them. But otherwise, it's
And
Not.
do you also use like social workers within the hospital to help transition folks to other services?
yeah, I'm not as familiar with how the inpatient social workers are referring people, but I know we are assuming that we're making referrals all the time to all sorts of services and trying to engage patients in a plan for their discharge.
Because I think that that's a good piece, and I don't know. So you added in ED to expand the Siri language, but I think it's like, how do we add a little bit more emphasis that, it's an identified issue, that there's a disconnect of getting somebody from an emergency department into an outpatient provider because there isn't anyone to help with that service linkage. And if you expand and you allow this community support and coordination to be occurring, it will improve this service linkage.
Yeah. Yeah, Amy?
So in regards to the emergency room with the peer support, I just so happened to have experience at Harborview in Seattle with somebody who had an intake into the ED department, who was identified as someone with a substance use disorder, and the process that happened over a number of period of time. And they were supported with the social worker, obviously, well, not obviously, but the social worker was very helpful in trying to identify resources. And then if I remember correctly, a doctor who was somebody, SUD doctor, came and visited with the patient and talked about their specific issue because it did involve a need for detox services, and that was the extent of it. The person was in the hospital there for quite a bit of time. There wasn't peer support that could have been very, very helpful in helping link that person to services, the warm handoff sort of thing. So I can definitely, like, just from my experience with that, while they were very good at providing things and talking about the things like that, that other piece of it was missing and could be very beneficial, in my opinion.
Yeah, and that's so when the Peer Pathfinder program started in 2017, one of the goals of the program was to embed a peer in emergency departments to facilitate that transition and to help people with that transition. But one of the challenges that we had with implementation with that was that a lot of emergency departments just didn't see it fitting into their workflow. That having a 9 to 5 peer wouldn't necessarily be as helpful as having, like a 24/7 way to connect folks to peers. They had space issues. They didn't have a place to put people. One of the cool things that's happening now, though, is the Scala Northwest project that's, I think it's primarily facilitating access to MOUD from emergency departments or within emergency departments. But then as a side note, also facilitating referrals to peer support services and recovery support services. So it might be valuable to bring in Liz Wolkin, I think presented, maybe that was to the SURSAC. I forget if she talked to the SUDISA, but it might be worth looking at the work that she's doing to figure out what that could look like in terms of facilitating the connection between the emergency department and follow-on peer services.
This is Brandy. One of the barriers for BHAs is the peer support services cannot be provided prior to an intake. So we can't use a peer support staff. And right now, the way that the rehab case management is written, it's a 24-hour facility. And so we have to have enough people coming from 24-hour facilities to staff someone so that they can actually do that type of engagement and transition utilizing rehab case management services. It's also a new, or not rehab, community care coordination. I think that, again, I'm bringing, my role on this team is a provider perspective and from an inpatient provider, but we also provide outpatient services. If we could have someone identified, at least from the provider side of things, that we could actually hire people to do that care coordination and bill services so that they can connect with EDs and they can connect with, medical clinics for people that are the high need. I mean, there are some people who are going to get a referral and they're going to follow through with their referral and make connections and show up and do their assessment. But there's a large population of people with mental health and substance use conditions that are not going to follow through, or that are given a referral and then, life happens and they don't make the connection to the provider organization. So I think if we expanded, what I'm saying from the provider perspective, if we expand that care coordination and allow it to be a Medicaid billable service, I'm suggesting here as peer, but we're also suggesting to expand the other credential types in this, to expand it to ED services and the homeless population for transit community coordination, that providers could hire individuals that can actually be that liaison between hospitals, medical clinics, homeless organizations, and help with assisting people in getting into services, and make a connection with the provider and a relationship with the provider workforce to get them connected. So like, for example, if they're connected with a peer or they're connected with any kind of credential type at a provider organization and they don't come for their assessment, then the provider network can actually reach out and reconnect with them and reschedule their appointments and do those types of engagement activities that we currently can't do.
So the challenge is really like getting that economy of scale where you can actually fund an FTE with the billable services that they're providing.
Yeah.
Right.
Well, correct. I mean, it's great because we work with a peer-run organization locally, which is wonderful. They have funding, but none of it, as I understand it, is Medicaid funding for them to bill that type of service, nor are they BHAs either. So yeah, I'm speaking from the BHA perspective, but I think it could enhance and improve the coordination with non-BHA providers.
I think with everything that Brandy said, coming at this from multiple directions, I think the hardest thing is we keep coming up with different language when in actuality, it's still the same thing. Like care coordination is still, it's at the end all be all it is case management, like, and it's expansive, and there's that difficulty of figuring out how to navigate. We keep creating all these new words for things that, and it's like, how do you get billable reimbursement for specific services for exactly what they are? Because each time we come up with a new terminology and new language, then we have to figure out who can do it and how they can do it.
I wonder if it would be helpful to pursue some kind of bridge funding to set up positions like this and get them to the point where they could be billing adequately.
Well, care coordination, technically, I understand it's similar to case management, but I think the point of it is very similar to outreach and engagement and getting them connected to services versus getting them active in with a provider who can provide case management services. Case management currently is a SUD billable service post-intake, not a mental health service post-intake per se. So I guess I was focusing more on what we now refer to as care coordination. I agree, language just changes over the course of time, but care coordination initially is getting someone into services so that they can have a service provider that manages the rest of their care and coordination, whether that's also care coordination or case management or whatever language post-intake or assessment. My intent was getting them to getting services so that they can actually complete assessments and intakes and have providers that follow them. This is prior to.
I have an example, Brandy, of exactly what you're talking about, so I'm so sorry to interrupt. For assisted outpatient treatment, which is an involuntary petition process, we've been having BHAs ask how they bill for the services that they're doing prior to the person being established as a client, because it's a lot of legwork. And Department of Health told that BHA that they would be doing those services under the behavioral health certification for information and assistance, because that permits them to do the service without having to have an assessment. Now, the difficulty gets into that is not a service that peers work under at this time. But that's that piece of that care coordination, and that was a recent advisement by Department of Health to that BHA, was making sure that they're certified to provide behavioral health information assistance. I'll have to look at that a little bit more, what that WAC is. But then it's still that same issue of incongruency between what Siri indicates and then like what a Department of Health WAC service indicates. So I think that the proposal that you guys are making, the recommendation of working to align things, is definitely needed.
Information and assistance is not a billable service for BHAs, according to the Siri.
Okay.
FYI. So I think that's great. Yeah. I'm wondering if we want to finalize, at least this working group, did we finalize our initial recommendations?
I put the notes that we had typed up, which I have not changed since you last saw them shared on my screen. I popped those into the, oh, it said failed to send. Okay. Well, I popped them into the chat anyways. Let me try that again.